This video will cover the pharmacology of specific agents used in the treatment of cystic fibrosis. Specifically, this video will focus on the agents that have not been covered in other IP courses previously. When it comes to the treatment of cystic fibrosis, there are several therapeutic approaches that are useful in the treatment of both symptoms and in the improvement of CFTR channel function. One target of cystic fibrosis treatment is the surface liquid dehydration, and this can be accomplished with hypertonic saline. Another target is the chronic infections that can occur in individuals with CF, and one of the ways to treat these chronic infections are with inhaled antibiotics like tobramycin. To treat the inflammation that occurs in the airways of individuals with cystic fibrosis, anti-inflammatory treatment with agents like azithromycin and ibuprofen is common. However, the majority of these agents have already been covered previously, and therefore this video will focus on the treatment of mucus obstruction using mucolytic therapy and the treatment of CFTR defects using CFTR potentiators and CFTR correctors, or drugs that rescue CFTR transport defects. There is one mucolytic therapy that is used commonly in individuals with cystic fibrosis. It is known as Doronase Alpha. Doronase alpha is a recombinant version of the human DNase enzyme, which naturally breaks down DNA. In the case of cystic fibrosis and the significant infiltration of immune cells and inflammation that occurs in the airways, what can happen is neutrophils and other immune cells become degraded and damaged in the airways, further contributing to the presence of viscous mucus. By treating with Doronase alpha, which is a DNase enzyme that breaks down DNA, this can decrease accumulation of cellular debris in the airways, thereby reducing viscosity of airway secretions, leading to improved lung function and reduced exacerbations. As demonstrated in the image on the screen, in a clinical trial comparing Doronase alpha nebulization to placebo, the percent of patients free of respiratory exacerbations was significantly higher in patients treated with Doronase alpha over 96 weeks compared to those given placebo. The first study to show benefit of nebulized Doronase alpha was reported over 20 years ago, and subsequently many studies have demonstrated improved lung function in patients with advanced lung disease, as well as in younger patients with mild disease. Doronase alpha is considered standard of care in patients over 5 years of age. As a recombinant protein product, Doronase alpha is subject to the possibility of a hypersensitivity reaction or a drug response that could decrease its effectiveness. As mentioned, it is administered as a nebulized therapy, and its main goal is to serve as a mucolytic agent, or something that breaks down mucus and decreases the viscosity of airway secretions. The next set of therapeutics we will talk about are known as the CFTR modulators. This is a set of small molecule drugs taken orally that have the ability to either potentiate the function of CFTR at the cell surface or to increase transport of CFTR from the ER and Golgi apparatus to the surface of the cell. There are several different CFTR modulator drugs available on the market now, and some of them are also present as combinations of both a potentiator and a trafficking rescuer. The figure on the screen demonstrates or illustrates the percentage of patients with cystic fibrosis that are eligible to take one or more of these agents. There's a small percentage of patients that are not eligible for CFTR modulator therapy, either because they have a missing, unknown, or incomplete genotype, or a very small percentage of patients who have a non-responding genotype, and this is less than 10% of patients. There's another small group of patients that are ineligible for CFTR modulators due to age because they are under the age of 6 months. The first CFTR modulator that was developed was AlexaCaftor, or Calideco. It is approved for one of 38 specific mutations in children 6 months and older. The next therapeutic that was developed is the combination of LumaCaftor and AlexaCaftor, or Orkambi. Approximately 40% of patients with cystic fibrosis are eligible for Orkambi, as it targets patients who are homozygous for the F508 delete mutation. The next combination was TessaCaftor and AlexaCaftor, or Symdeko. This is also eligible for approximately 40% of patients, and as you can see, has significant overlap with both Orkambi and Calideco, as it is allowed in patients who are homozygous for F508 delete or with one F508 delete mutation and another of 26 approved mutations in children 6 years and up. The last agent to be developed and released is a triple drug combination of AlexaCaftor, TessaCaftor, and AlexaCaftor, or Trikafta. The vast majority of patients with cystic fibrosis are eligible to take Trikafta, upwards of 80%. And this is because it is allowed to be utilized in individuals who are homozygous or heterozygous for F508 delete. So any patient that has at least one copy of F508 delete is eligible for Trikafta if they are 12 years of age or older. Fortunately, a large percentage of patients who are eligible for these medications are taking them, and they are effective in rescuing the function of the CFTR transporter. First, we'll talk about ivacaftor alone, or Calideco, which is known as a potentiator. This is a drug that is able to potentiate or increase the function of CFTR located at the cell membrane. It does this by increasing the frequency of channel opening, which allows for more chloride to be transported. It is indicated for approximately 10% of patients who have active and transported CFTR channels, but with reduced function compared to wild type. This is especially useful in the treatment of CFTR mutations that fall into classes 4, 5, or 6, where CFTR is trafficked to the surface, but is either less functional, lower quantity, or less stable than wild type protein. Ivacaftor is a substrate of CYP3A4, and it is metabolized by the CYP3A4 enzyme. Therefore, there is some dose reduction required with concomitant 3A4 inhibitor therapy. Given its inhibition of CYP3A4 and its heavy first-pass metabolism, ivacaftor also has the potential to cause hepatotoxicity. Ivacaftor has a half-life of approximately 12 to 15 hours, and therefore is typically dosed twice per day. The next CFTR modulator to be developed was LumaCaftor, which is prescribed in combination with ivacaftor as Orkambi. LumaCaftor is what is known as either a corrector or a conformation stabilizer for the CFTR transporter. It assists in trafficking CFTR protein from the ER and the Golgi complex to the cell surface. And for this reason, it is most useful in correcting the mutations that fall into class 2. One important thing to note about this is that the F508 delete mutation does fall into class 2, and that encompasses the vast majority of patients with cystic fibrosis. When given in combination, LumaCaftor serves to correct or increase trafficking of the CFTR channel to the surface of the cell. Now that there is increased CFTR protein found at the cell surface, ivacaftor can act as a potentiator to increase function of channels that are trafficked to the cell surface. And therefore, together, LumaCaftor and ivacaftor both rescue channel trafficking and channel functioning. Orkambi is indicated for patients who are homozygous for the F508 delete mutation over the age of 2. This equates to approximately 40 to 50% of patients with cystic fibrosis. Of note that ivacaftor is metabolized by CYP3A4, as we discussed previously, and also can lead to some hepatotoxicity. LumaCaftor, on the other hand, is not extensively metabolized and primarily undergoes second phase metabolism like glucuronidation. Some additional adverse effects associated with the use of Orkambi include the possibility for respiratory distress, hypertension, and cataracts. The half-life of LumaCaftor is a bit longer at around 25 hours, but the LumaCaftor-ivacaftor combination is still dosed twice a day, approximately every 12 hours. The next CFTR modulator developed is TessaCaftor, which is administered together with ivacaftor as Symdeko. Similarly to LumaCaftor, TessaCaftor is a corrector or conformation stabilizer that allows CFTR to be properly trafficked to the surface of the cell. The main difference between TessaCaftor and LumaCaftor is that TessaCaftor has activity and ability to correct trafficking of mutations other than just F508 delete. Specifically, Symdeko is approved for treatment of patients with either homozygous F508 delete mutations or heterozygous with one F508 delete and one alternative mutation of 26 different approved types. Therefore, Symdeko is eligible to be used in a slightly larger group of patients, closer to 50% plus. However, Symdeko is also only approved for patients 6 and older, and therefore that does decrease the population that is eligible to a certain extent. Both TessaCaftor and ivacaftor are metabolized by CYP3A4, and due to the extensive first-pass metabolism and utilization of a very common CYP enzyme, they do have the potential to cause some hepatotoxicity. This is in addition to some other adverse effects like respiratory distress, hypertension, and cataracts. The half-life of TessaCaftor is closer to 25 hours, and therefore this drug is dosed with the combination being taken once in the morning and then a separate dose of ivacaftor alone being taken by itself in the evening. Said another way, TessaCaftor only needs to be administered once per day, whereas ivacaftor needs to be administered twice per day, given its shorter 12-hour half-life. The most recent CFTR modulator to be approved is AlexaCaftor. AlexaCaftor is another CFTR corrector that assists in trafficking misfolded CFTR protein from the ER and Golgi to the cell surface. It is given as part of a 3-drug combination that includes AlexaCaftor, TessaCaftor, and ivacaftor, also known as TRIKAFTA. AlexaCaftor is different than either TessaCaftor or LumaCaftor because it is able to assist in the transport of many additional CFTR mutants beyond just the F508 delete mutation. Therefore, TRIKAFTA is approved for any patient over the age of 12 who has either 1 or 2 copies of the F508 delete mutation. This means that TRIKAFTA is able to be prescribed to approximately 80 to 85% of cystic fibrosis patients, which greatly expands the reach of those eligible for a CFTR modulator drug. As the image on the screen depicts, TessaCaftor and AlexaCaftor assist in trafficking of CFTR protein from the ER and Golgi apparatus to the surface, which corrects class 2 type mutations. Ivacaftor, as we've discussed previously, is a CFTR potentiator that is able to increase the frequency of channel opening in channels that are found at the cell surface. All 3 drugs in this combination are metabolized by cytochrome P450 CYP3A4 to both active and inactive metabolites. Given this, it is important to watch out for drug-drug interactions through the CYP3A4 enzyme, as well as the possibility of developing hepatotoxicity. In addition, other side effects are similar to the other CFTR modulators, including respiratory distress, hypertension, and cataracts. Both AlexaCaftor and TessaCaftor have a half-life of approximately 25 hours and only need to be taken once per day, whereas IvaCaftor, with a half-life of closer to 12 hours, must be taken twice a day. Therefore, Trikafta dosing typically includes one dose of the 3-drug combination in the morning and then a second dose of IvaCaftor alone in the afternoon, approximately 12 hours apart.